Hi everyone, we are here with Professor Bell, who is Vice Chair at the Department of Cardiovascular Medicine in Rochester, Minnesota, the Mayo Clinic. Good morning, Professor Bell. Today you talk us about the advances in coronary artery disease in the last year in the studies that we saw published in important journals. You focus on the eternal battle between PCI and CABG, and specifically to the progress and the news that you acquired on a physiology-guided approach. What would you summarize for us about this topic?
Yes, we talked this morning about the so-called FAME-3 trial. This was a study that was looking at patients with multi-vessel coronary artery disease and whether using FFR, so a physiologic measurement of the severity of coronary artery disease, using that to guide PCI in the patients who are randomized to having PCI using FFR as guidance versus sending patients to surgery for bypass surgery where the assessment was made just purely on the angiogram without any FFR. In that study, it showed, and it's a relatively early follow-up so far, that the patients who had FFR-guided PCI did not do so well as the patients who had bypass surgery based purely on the angiogram. So this was, I think, a little bit of a surprise, but as we think about the use of FFR in patients with stable coronary artery disease, maybe many of these patients have more simple or less complex disease compared to the patients in this study who had multi-vessel or three-vessel disease. And I think that at this point, we don't use that to send the patient to bypass surgery. And I think at the end of the day, the patients who had bypass surgery had more complete revascularization, compared to the patients who had PCI. So I think that this is perhaps really a study of the completeness of revascularization, showing that those patients who have incomplete revascularization, which would be these PCI patients, don't do quite as well in the follow-up.
Great. So to summarize, probably not physiology-guided approach in all patients with multivessel disease, also for PCI, and probably an angiographic approach as the routine method for coronary artery bypass grafting surgery. If I got it wrong, Professor.
No, I think that's right. I think it also tells us that patients who have three-vessel disease at this stage, we don't really have any evidence to say that they're doing as well as patients who have bypass surgery, particularly if they have more complex disease. The only thing I will stress about this study, though, is that currently it's recommended that we use intravascular imaging either before or certainly during and after the stent placement, and whether that's with intravascular ultrasound or OCT, that this helps optimize results in getting the very best results. In this particular study, that was only used in about 10 or 12% of patients. So perhaps just a word of caution there, but at the moment, maybe disappointing results for PCI in that study.
Oh yeah, I think this is surely a central point and key message. And so we also talk about a really relevant study for the practice of many outpatient cardiology. We saw that a very important study has been published on the correct form, what's the best strategy to follow up our patients after percutaneous coronary intervention in the setting of coronary artery disease and stable patients. So what did this study tell us?
So we're referring here to patients who've had successful revascularization with PCI. And I think that there is an overarching message here, and that is that in patients who don't have symptoms in general, that there are not a lot of data to support that we should be routinely screening such patients. But in these patients who have undergone successful PCI, this was called the post-PCI trial. It was randomized to patients to then have routine surveillance with stress testing, mainly nuclear studies, versus just standard care and only investigating them further if they've had chest pain. And it really showed that in patients who underwent routine surveillance, and half of those patients actually had 2 stress tests, that over 2 years there's no significant difference in the outcome in those patients to the ones who were just routinely followed up clinically. And I think this is an important study because I think there's been some inconsistency in the way these patients are followed in various hospitals or regions for that matter. And typically we should not be doing routine surveillance and really just acting on symptoms alone. I think that this would be very, very important to consider when you're following up these patients, because the results from PCI these days are so predictably good. But again, as I said, emphasizing that we shouldn't be doing routine tests on patients who are otherwise asymptomatic. And I think this has huge cost-saving potential for communities.
That was a great message. Do you think, is there any anatomic or functional subset that may merit follow-up routinely despite the presence or the absence of symptoms?
Yeah, well, that's a very, very good question, and I think that's one that's easily answered in 2 ways. First of all, I think the majority of PCI that we're doing these days is relatively complex. I mean, we use a lot of different devices, whether it's lithotripsy, rotablator. The disease is very diffuse, and we're tackling more and more complex disease. In that particular study, though, they only included patients who had high-risk characteristics, so they were treating left main disease, bifurcation disease, diffuse disease. They had acute coronary syndromes, they had diabetes. So this really pertains to a relatively high-risk population, and despite that, there was no difference in outcome if they had routine stress testing surveillance.
Right. I think this is a very reassuring message, I would say, and I think that we should really stress this concept and pursue this in clinical practice. Thank you for being with us. It was a pleasure, Professor Bell.
You're very welcome, and thank you.